So I believe it's time. Welcome for today a webinar presentation of the HyperPED-COVID Registry. I'm Anne-Sophie Korganov, the research working group chair, and I will moderate this webinar with Marielle Jean, who is the molecular testing group chair. As you see on the right of your screen, you have a discussion chat, and at the end of the webinar, we will ask questions to the speakers to go on with the discussion. Today, it's my great pleasure to introduce Professor Gatorno, who is the president of the International Society of Systemic Autoinflammatory Diseases and the head of the Center for Autoinflammatory Diseases and Immunodeficiencies in Genoa in Italy. He will share the talk with Elisa Patrone, who is a research assistant working and managing the HyperPED-COVID Registry. As discussed with them, just to illustrate the important need for their work, I will start with a short observation from our department. Sorry. This is about a clinical case of a post-COVID inflammatory disease. So it is the story of a young female student, healthy with no past history, who presented in middle March 2020 benign SARS-CoV-2 infection. She told us about a loss of smell and taste and tiredness in a familial context, with also her father and her brother sick, but no PCR was done, and then she goes well in the next few weeks. About 6 weeks later, she referred to consultation and then to our department. So that was the end of April, with a high fever, pain, especially back pain, and then abdominal pain, nausea, and sore throat. She had an important inflammatory syndrome, and then on the other days, the temperature raised to 40 degrees with headache, arthromyalgia, with edema of arms and legs, and an increasing inflammatory syndrome. We did research for SARS-CoV-2 infection, which remains negative, and all bacterial and viral investigations were inconclusive, including lumbar puncture. We did pulmonary and abdominal tomography, which only shows some mesenteric and retroperitoneal centimetric lymph nodes. Then at the beginning of the week after, the situation continued worsening. The fever was still present, and she started with a hemodynamic instability, hypotension, tachycardia, and diagnosis of cardiac decompensation. The inflammatory syndrome was major, and despite large spectrum antibiotics, and she presented signs of cardiac failures with an increase in pro-BNP, in troponin, and with a negative T waves on the electrocardiogram, and a global hypokinesia with a left ventricular ejection around 51% on echocardiography. Renal and hepatic functions were preserved. She was quickly transferred to intensive care with tachypnea, hypoxemia, low blood pressure, and at this time she presented diffuse pain with painful cervical lymph nodes, pharyngitis, strawberry tongue, and a new dermatologic sign with erythema on both arms and legs. She developed progressive important heart failure, which needs dobutamine and mechanical ventilation. At this time, we discuss the diagnosis of post-COVID-19 multisystem inflammatory disease based on the chronology, on the absence of other etiology, the absence of evolutive SARS-CoV-2 infection, and on the very important inflammatory multisystemic presentation, and also by analogy with a few cases at this time, because we were in April of last year, of Kawasaki-like disease in children in Italy, in France, and in Great Britain. So by analogy with these other cases, we started a specific treatment with methylprednisolone, immunoglobulin, intravenous immunoglobulins, 2 grams per kilo for during 4 days, and we coupled the treatment with aspirin and intravenous heparin, considering the presence of antiphospholipids. She had a very rapid positive evolution and was discharged of hospital on May 17th with a drop in steroid therapy and aspirin. We had the serology some weeks after, considering that she benefited from intravenous immunoglobulins, and also that at this time the serology was only the serology technique was only ongoing in our hospital. And at the last consultation in December, she had no more treatment and was cured. So here you have the electrocardiogram with the negative T waves on the in lateral, and the IRM we did some days after the transfer in intensive care. We did not see such things with only a slight edema, a peripheral slight edema with a rehaussement after each injection. So I thank you very much for your attention, and this was just to illustrate the important need of registry and of therapeutic or investigation in this case. I just now leave Marco Gattono and Elisa to present their registry.
Okay, thank you very much, Anne-Sophie. It's a great pleasure, of course, to be here and to share with you this initiative that start from not from the conclusion, but from the beginning. Sorry, start from the ERN-RITA. I am here as a representative of the ERN-RITA, as the responsible for the stream lead of autoinflammatory diseases. And today I would like to present this initiative that we think are really important, and also in a way rather new. We will see, it's very ambitious, I have to say, but I hope that you can appreciate the novelty of this initiative. You know very well that after some weeks or some months after the first wave of the pandemic, there was this very interesting observation coming at the beginning from Bergamo in Italy and then all over Europe on this strange phenomenon of a multifactorial inflammatory condition that has been called in different ways systemic inflammation with multi-organ failure, cytokine storm syndrome, macrovascularization syndrome or Kawasaki-like, and so on. In most of the patients that have usually not a positive test, but a positive serology for COVID-19. For sure, a post-infectious condition. And that has been now described very well as Miss C. And you know very well the clinical picture, and you have learn about data also after the interesting case that you have already heard by Anne-Sophie. This is a relevant problem. You know also the severity, as you've seen, as you know, of this condition that is completely new and peculiar and typical, have some similarities with Kawasaki disease, as you know, but there are also completely different manifestation, and the severity can be rather important. So the brief history of the project, why we are talking about this kind of registry that raised from ERN-RITA. You know that it was the European Reference Network that at a certain point asked to ERN-RITA to start an initiative on this rare condition that was related to COVID-19. So was Nico Woolford, our coordinator, that asked me as the responsible for auto-inflammatory stream to think about a possible common registry in the context of RITA. So the idea was to develop a common effort among different societies under the umbrella of RITA-ERN, but the novelty is to try together all the different specialities and also the knowledge that we have within the RITA-ERN. So the characteristic of RITA-ERN is to have on board pediatric rheumatology, patients that are doctors that are dealing with immune deficiencies mainly, or with autoinflammatory disease, vasculitis. And so that will be the possibility to merge the expertise of different experts. This is the real adding value of our ERN, I think. And the idea was indeed to elaborate a common forms that can be used by different society, also independently if we want, but without any problem in the possibility to merging the information. So not to have a ESID initiative, a PRESS initiative, a ESSAID initiative, and an ERN initiative, but try to find out a common initiative. That was, in my opinion, a rather new approach. At the moment of the discussion, May 2020, there was already a number of national initiatives, registry that were ongoing. Already some first reports have been published, and there was some other international research initiative, like, of course, the genomic studies on COVID in general, but also on ISSAID, or other that were planned at the moment. So the idea was to build up something that did not overlap or in a way contrast at all what was happening in the national, let's say, initiative, because every country, in a way, some more, some less, start to collect their national cohort. We didn't want at all to enter in competition with these initiatives, but just to make a step forwards. So to let's say, to start thinking to merge at a certain point the experience of different countries not in the national level, but of course at the international level, with a unique form that could, in a way, represent all the different societies that are involved in the immune diseases of children. So the first step was to institute and to make a steering committee with a representative from each society. That was, of course, very important. And in the meanwhile, we started also two different surveys. One survey in the context of PRINTO, I will tell you more, and another survey was in the context of ESID. It was related to the impact of COVID-19 to the population of patients with primary immunodeficiency. The steering committee was rather large and was a political balance, but was very nice to have a number of different expertise. As you can see here, we have a retired representative, that is Karin Wouters. I think it's here, she's here, and some ESID representative, the press representative, the Pediatric Rheumatology European Society, the ISSAID representative, the Society of Auto-Inflammatory Disease, and of course also the people from PRINTO. You know, PRINTO is a large network that is very active in pediatric rheumatology. He is here in Genoa. The senior scientist is Nicola Ruperto, and as you know, PRINTO has a large expertise, huge expertise in collecting data. Maybe you have heard about the Eurofever registry, that is a large international registry on auto-inflammatory disease. And also PRINTO has a very large network in Europe, but not only in Europe, all over the world, as I will show you. So the goal of the steering committee was, of course, to establish a common registry for the different societies and different expertise, to build common forms. That is very important, to collect the same variables, to establish inclusion and exclusion criteria, of course, and of course to design a common study protocol for the ARB and ethical review board's approval. And that's what did the steering committee. In the meanwhile, as I told you, in the context of the PRINTO network, we start to have from April, the end of April to the end of June, a sort of survey among the PRINTO centers that are more than 200, to have an idea of the number of the patients that has been seen from the beginning of pandemic until June 2020. So the step was building the form. So we, as usual, we make a literature search with all the signs and symptoms that in the meanwhile were published in the different papers from UK, Italy, UK, and other countries, in the United States, of course. We had a number of rounds of discussion among experts to define the correct, let's say, forms, all the correct terms, how to build that. And then we came out to have the final common forms. And we decided that there will be two different platforms to collect the data. One platform were related to PRINTO, and from its national history, of course, the community that is related to pediatric rheumatology and the ISSAID community, that is the International Society of Auto-Inflammatory Disease, was really linked to the PRINTO network. And so these two societies decided to use, let's say, the PRINTO platform to collect the data, but however with the same forms, the same system that could be used by ESID, that decided to have and to collect the data through its registry, very well-known registry. So I would like to give the floor to Elisa, that is our research assistant now, because she will introduce a little bit on the form that, of course, is on the web. Please, Elisa.
Yes, thank you, and good afternoon to everybody. As you can see in my screen, we are logging in to the PRINTO web system where the forms are hosted. As Dr. Gattorno has just said, the CRFs are common, have been agreed together with the other societies involved in the project in order to ease the merge of data in the analysis phase. As you may have noticed, I have first entered a personal password for each investigator, and then I am entering a center password which will ensure that the data are pseudonymized. So we as a coordinating center will only see the patient's code. Here, for those of you who are not very familiar yet with the PRINTO systems, you will find all the lists of patients enrolled in your center, which for this demonstration is a fake center with all the possible PRINTO studies that can be active in your site. If you want to add a new patient for the HyperPED-COVID registry, the first step is to add a new subject. And we have here a census in which we can indicate the basic information. Of course, this can be adapted to your national regulations. So for example, if you are allowed to enter only initials or maybe a nickname, so for example, a center code with a number, you can do so. At the same way, for the birth dates, we can use also, for example, the 15th of every month, if you are not allowed to put the exact date, or again, the 15th of June. The first form requires some basic information as disease onset, diagnosis date, and first visit at your center. At this point, we have enrolled. We need to enroll our patient in the study. So we select the project. For this demonstration, we will use today's date, so when we actually enter data, and mark the inclusion criteria for the study, which are an age between 0 and 21 years of age, a fever above 38 continuously for at least 24 hours, an involvement of organs above the number of 2, a positive test for COVID or an exposure in the 4 weeks previous to the onset of symptoms, and some laboratory abnormalities, which you can find listed here. The exclusion criteria is mainly just one, and that is the possible explanation of the clinical picture by any other pre-existing condition. And this stage, we can enter for the centers which need it, the consent from the family or the patient. As you can see here, we don't need to upload anything just to confirm that we have the consent. And we can now actually move to the visit, to the actual visit. Again, we put the date of today for data entry. And you can see here that automatically the system suggests you to enter a retrospective. This is because you will need all the possible information on the patient outcome while filling in the forms. At a later stage, it will be possible also to add a follow-up for your patient if you are interested in signaling to us other manifestations. Here we have the actual forms for the study, which I will show you very briefly just to give you an idea, which are divided into general information mainly related to the inclusion and exclusion criteria, a summary of the clinical manifestations for the patient, the drug therapy session, and then some results about laboratory exams or diagnostic procedure. I will show you quickly what I think are the most important features. So, in the first form, you are required to indicate the date of fever onset, hospital admission, fever resolution, and the date until which you have data on your patient. And that's the first thing I was telling you about, the need of filling in the forms just when you are sure about the outcome. You can indicate if the patient needed intensive care admission. and something about the outcome. You can indicate also if there are any sequelae for your patient. The second form is strictly related to the COVID positivity. So you can put, if you have an evidence of swab for your patient, serology tests with the date, or, as we said, just the confirmation of a contact with a positive patient. You have the possibility to enter further tests or information. The vital signs form is very quick. You can indicate if this list of symptoms were observed at the moment of admission or appeared after admission. We can put some examples here. But what I think is the most peculiar section is the sign and symptoms section. As you can see here, we have a long list of organ systems, which we can select here from the summary. If you want to check what is included in, for example, I don't know, the lymphoid organs manifestation that we are interested in, you can click on the PDF and you will see the list of what we will collect. And so for this example, we select the lymphoid organs and the cardiorespiratory systems. And you will see that in order not to take too much of your time, the forms which you don't have selected are already considered completed as not present. Instead, when you have indicated the involvement of one particular system, you can enter more specific information on that system. Again, you have often the possibility to specify in more detail with text fields the manifestation of your patient. Another form which I would like to show you is the drug therapy. But as you can see here, we are interested in knowing if you have collected samples for your patient. Of course, this is not mandatory for the participation in the registry. We are just interested in checking this information in order to evaluate future studies. So you can tell us if you have collected any and which ones. As I said, the drug therapy session is quite interesting. You can add a new drug, choosing it from a list we have agreed. There are not just strictly drugs. You can see here there are just other type of intervention that we have considered for the study. For every drug, you can put the start and stop date and the reason for discontinuation. So, for example, the patient just needed 1 day of oxygen supplementation for improvement. What is interesting is the possibility to add cycles of drugs. So just to give you a very quick example, we can indicate that there was a steroid cycle, which we can imagine has been tapered down. So in this case, we put just the initial date with a dose. And then we will indicate that the dose has changed. At this moment, prednisone, we can add a new cycle starting from the following day. And you can repeat the same logic for all the drugs and the cycles. So from 28th of July, and we can put another month, for example, just to be quicker for the patient. When you are satisfied with the summary of drugs that you have entered, you can confirm the page. The last thing I would like to show you before giving back the word to Dr. Gattorno is the laboratory test page. You will see here that we are interested in recording the values at in three moments: the value at the admission and the minimum and maximum value ever recorded during hospitalization of your patient. Of course, as admission, we considered valid all values entered within 1 week from admission, because maybe some of the particular tests we are requiring have not been performed on the exact day of admission. In any case, you can indicate that the test was not performed. And in order not to frighten you with all these lists of tests, we have also set up a tool which will allow you to indicate just one time the unit you use and the normal ranges for your hospital, so that you will find this section already completed for the following patient that you need to enter. And the last form is the diagnostic procedures. And we ask you here to indicate which tests have been performed for your patient and the result. Again, you have the possibility to specify if the option you are looking for is not already provided. And after that, your patient is completed. You can confirm the data. Here you will see a button that will allow you to confirm the data. And you will be able to enter further information if you wish to with another visit, or using the ticket system to communicate with us in order to work further on the patient, for example, changing data or asking us something. Maybe at the end of the presentation, I will put my address in the chat. So in case any of you is interested in starting the procedures for opening the center and enrolling with us, we can work together to provide your ethics committee the needed documentation. And for any questions, I will be available. Thank you.
Thank you very much, Elisa. I think that was important. Just to finish the presentation, of course, just to give an idea, during the survey from April and June 2020, we collected, in terms of a general just idea of how many centers were followed by different centers, just in that 3 months, 373 children in different centers in the PRINTO network. Of course, now the patients are much more. Of course, which are the scientific goal for that? I finish with that just to have some discussion afterwards. Of course, what is the meaning to have this kind of registry? What we know already, we know that there has been a lot of, as I told you, a lot of national and also international activities, also related to also different subspecialties. There are surveys and registry maybe for cardiologists, for people working in ECU, and I mean this is a large, of course, amount of possible initiative. Now we are, of course, linking to who the people that is dealing with immune-mediated diseases. And of course, especially in some countries in Europe, and, there are of course already several reports, and this is an interesting study, meta-analysis of published of European Journal of Pediatrics some weeks ago, that collect more than 900 patients collected in different series. You can see here with low number, some very high, low number each series, but cumulative very high number, and also case series. And was, of course, we can already have a lot of information of this condition on the clinical manifestation, and of course on the treatment that is very diverse. You can see here a completely different approach. I think it's very interesting here to understand why. But if you look more in detail, there is a very huge variability among the different series. This is another meta-analysis, and it's interesting to see, for example, which is the prevalence among the different series of the positivity of ACRP, and also, for example, completely different incidence of aneurysm and dilatation in different centers in respect, for example, to left ventricular dysfunction. So there is.
Marco, are you showing slides?
Oh, sorry. Yes.
Okay,
actually, yes. Maybe
screen then.
Janette, you can help me, because okay, sorry. I'm very sorry.
See a slide.
Oh, sorry. However, I was just showing here the sorry, because I hope that now you can see, and you can see here what came out from the meta-analysis of it already, the meta-analysis that is already available, the different manifestation and the diverse treatment I was referring to. But also I was telling that there is also a lot of variability among the different cohort, for example, in the number of patients that have a positive test, but also in the number of patients that have a coronary aneurysm and dilatation. Some have a very high number of Kawasaki-like condition. And of course, again, see here the variability in the presence of left ventricular dysfunction, so myocarditis. So the population so far available are really mixed and really variable, and there is not a complete geographic coverage. So what is still lacking, and this is the meaning why I think we should go on with this large international registry, because we lack an homogeneous picture of the problems among different European countries. We lack a comparison among different regions in Europe and also outside Europe for different health system, economical level, and so on. We lack long-term follow-up data. Do we have any long-term damage, complication? As Elisa told you, there is the possibility to have a second visit and is highly suggested to have a second visit that is the second visit of the last follow-up. Everybody of us, anyone is, all of us are following this patient, of course, and it will be interesting to see if there are some sequelae of in this patient in the long run. And then, of course, to have a potent tool for further European initiative, because if we know if the patients are collected and the samples are collected, it's very important to know where the samples are. So the aim of the project, as I understand, is to collect information, the presentation, parameters, clinical outcome, and so especially the long-term follow-up, and to connect with the different countries. Elisa already showed the inclusion and the exclusion criteria. I don't go in detail. This is the study flow, of course, is the classical study flow. PRINTO, for the PRINTO part, can help you a lot on ethical board submission. And the state of the art of enrollment, we are now, of course, the system is very, let's say, rather an elephant, because as you understand, is very, very complicated, very complex, and of course, with all the ethical board issues that needed to be taken, and so we are not in a hurry. We want to do in a very efficient way. So we start the enrollment a few months ago. We have already 154 patients enrolled, different centers that are open for enrollment or that are ongoing for the submission to the ERB. You can see here the center in Europe and the countries that are already actively enrolling, and most importantly, the countries that are, let's say, finishing the ERB approval. And this is not only an European network, because of the fact that we have PRINTO that is an international and not only European, and also an international society, the International Society for Auto-Inflammatory Diseases. So it is automatical that we will use also this tool for other countries, and indeed I have to say that there are already enrolling centers for extra UA and also a number of different countries that out of the European Union that are starting, they are doing all the procedures for the ERB. So the challenges are a lot. Unfortunately, we do not have incentives for centers. Is just on the voluntary basis. The problem of the ESID part is the ESID platform is not ready, and so we are discussing with our friends of ESID how to do, if they are willing to start the same let's say initiative, of course using the same forms. If they are willing to suggest to the ESID representative also to include the patient through the PRINTO website, they have to decide, I have to say. And of course, one challenge could be the presence of national initiative. This could be a limit or an opportunity. Of course, a limit because there will be a possible duplication of the work. There are already established multi-specialist national network, and sometimes it's not that easy to deal with another international network that is more specific for a sub-specialization. The pros, however, that we can use the international registry for national activity. So, for example, I don't know, Argentina can decide to use this registry and to evaluate his their patient, using this registry and analyzing all the Argentinian patients using this tool. Another possibility is the possibility to sharing the data with the already existing national initiative, or with a merging of the data. That would be, of course, fantastic, or at least with an aggregate of the data. That could be, in any case, rather important. And I finish here just to give 10 minutes for the discussion to tell you about the Italian experience. So as you may know, two friends of us, two pediatric rheumatologists, Marco Catalini and Andrea Taddio, in Brescia and Trieste, started an initiative in the context of rheumatology study group in Italy, and they were able to collect a relevant number in the first wave of 149 patients from Italy. The idea, discussing with Marco and Andrea, is we understood that when we revised the forms, 95% of the were common, the variables were common, so there was a lot of common variables. We are, let's say, exploring the possibility, the technical possibility to merge data. There will be ethical issues, of course, and we will ask a written permission to share the data. And however, from May 3rd, Marco and Andrea were very kind to say to communicate to all the centers that from that day the national registry will stop, and all the new cases should be let's say included in the international registry, just to facilitate communication between the two registries. What we would like to do is to start a number of, if possible, national subcommittee. So together with the steering committee, there will be an Italian national subcommittee, I hope a French, a Spanish, and so on, just to try to merge all the different initiatives that have already ongoing in the different countries. So the registry is open. You can write to me or to Elisa or to Printo, and we have an international registry. The first initiative that is linking different society under the umbrella of ERN-RITA. I think it's a very important message for that in this moment of division, to make something all together. I think that RITA healthcare providers are asked to actively participate. It will be very important for each center to send their patient. We have the possibility to homogeneously collect data across Europe and the rest of the world. We will have data on long-term follow-up, possibility to merge previous national initiative, and have a good tool for further European initiative. So I would like to thank everybody in the council and the committee, and the Printo member, Elisa, mainly Eugenia Mosci, Luca Villa, that is webmaster, and the first sub-committee, that is the Italian sub-committees with Marco Catalini and Andrea Tadino. Thank you very much indeed.
So thank you very much, Elisa and Marco, for this great presentation. I found the registry presentation and forms very clear and interesting. So it's essential to merge and make these registries to better answer questions about the clinical presentation and treatments. There are not so many questions, so there is only one question for Elisa from a recruiting center for Printo studies, and they just ask, they do not see the registry label in the common area, and ask how they can activate the registry. So I think maybe you can answer directly to them. Yeah.
Yeah. Thank you for the question. Thank you for the question. That is because from a technical point of view, the logo of the study is added just after ethical approval or after the confirmation that ethical submission is not necessary. So just if you are already working in other Printo studies, just contact us and we will make sure together of what you need to activate for the HyperPED-COVID registry. Thank you.
Thank you very much. I do not see other question in the chat. I have one question from the children included. What's the ratio of the young adults?
So the age limit is 21.
Yeah, young adults. I mean between 15 and 21.
Yeah, so they should be included. So it's from 0 to 21, everyone should be included. So I think it's a wide range of age. It would be very interesting to see indeed the differences, because we have the experience in the first wave that the majority of our patients were very young and with very typical Kawasaki-like manifestation. It was very interesting. In the second wave, we have very few patients like that, but much more older patients, 8, 9, 10, 11, with a clear-cut MIS-C phenotype. So this correlation with the age would be very important. And also, it's interesting the pattern according to the different time of the pandemic. That would be interesting. I think there is a question on the possibility, sorry, Anne-Sophie, I see a possibility to merge, collaborate with the UK lead international study BATS. If you allow me, I can try to reply. I see in the chat. And
yeah, there is a yes. A very nice initiative. Have you considered to collaborate with a UK lead international study BATS? Yes.
Yes. So of course, will be. We still love UK a lot. So and and UK, of course, is a part of this. And what I said for the Italian experience, that in the meanwhile has already also included other patients in the second wave. Of course, that would be also the case for the excellent experience of BATS. We're more than happy. Our idea, I have to say, we are discussing to our colleague in France and in other countries, is to start actively in Sweden and so on, start actively to call everybody and to start a possible agreement, because we have to explore the possibility, really the possibility to collaborate at the international level. Especially with
thank you. I don't see other questions. Maria, would you like to add something?
Yeah, I was wondering the amount of time, for practical reasons, the amount of time it takes to include a patient, and if it's possible to include 10 patients at the same time automatically. Of course, I'm always to copy it from other systems, or are there, do you foresee technical problems to do so, or would it be possible? If in one institute you have several patients you would like to include, to do them all at once instead of one by one?
No, Elisa, if you want to reply. No, okay, I can reply,
No.
but you should do individually. Of course, it takes time. Of course, fortunately, each center do not have huge amount of patients in respect to other rare diseases or diseases in a way. So I think, and we had something like 20 patients, and it was not that difficult. Of course, it takes some time. A resident or research assistant have to do that. Is taking some time. Unfortunately, we do not have any money to reward the centers, but I think it's feasible, rather feasible. Okay. Especially the first part, the clinical part, is very easy, very quick. What is a little bit more tricky is the part of laboratory examination that takes a little bit more of time, unfortunately.
In any case, just to add a few words, as you have seen, each single form can be saved individually. So you are not forced to complete all of your patients
yes.
at the same moment. So you can enter the information you have available and everything remains saved in your database.
Okay.
Excellent.
Okay. So thank you very much. I think we shall end now if there are no other questions. So I have to say that we have a date for the next RITA webinar, which is now fixed at May 21. And it will be on clinical guidance for vaccination in children with rheumatic diseases, with Professor Josef Jusiel as moderator and Professor Nastasia Toplaka as a speaker from Slovenia. So have a nice end of the afternoon.
Thank you. Bye-bye. Thank you very much.
Bye-bye. Thank you very much, Marco, Elisa, and Maya.
Thank you.
Goodbye.
Bye-bye.